how we began was just a call out meeting to faculty and residents. And I think it's important, one important distinction here is that when we started that, the call out was obviously everyone was invited to join, but I really wanted leadership, because when you send out an email saying, do you want to be involved in DEI work? You know, it's easy to raise a hand and say yes, but I really wanted people to show up. The second part about that is that resident leadership was key. And I talked with this, we just finished our marathon of residency applications all on Zoom. And so many of them are involved in promotion of community equity work and advocacy work already. And they have really come up in I mean, I'm not that old, but they really have come up in a different way through both their undergraduate and their medical education training in terms of these areas. Both their cultural experiences are different than mine, and the formal training that they have received in terms of advocacy and diversity. And so we need them not only to participate, but to lead, because this is collaborative work. And then I also think that it's important to have some intention about who is joining in. So obviously you need a diverse committee. There needs to be a person of color representation, but also allyship is very important. We also, in that initial meeting, took stock of our resources. So we were very lucky to have Dr. Taylor, who's one of our FPRMS doctors, who has a certificate in diversity. There are many resources within the hospital. There is a GME diversity chair. There's a hospital admin diversity officer. We have a lot of work happening in our own city within Charlotte. And then of course, as some of what Dr. Evans also alluded to, there's a lot of work, both local, national, and regional with APGO. So when we first set out to just get started, we tried not to, have this huge planning. We just wanted to get the ball rolling. And so we really wanted to just open up a conversation. And so our first event was a roundtable conversation with some of these key stakeholders that we identified from both our department and our hospital system and our city. And I'll speak a little bit more about that in a minute, but I think that that's important because we didn't spend months making an agenda, setting up all of these expectations. We wanted just to get things going and start the conversation. And also at that point, we didn't really know where this was going to take us. So this was sort of an introduction and opening. The other thing is, in particular, as it pertains to resident involvement, the last thing I wanted was this to feel like another requirement, another check box that they had to check. And so I wanted there to be a pretty low barrier to entry for both faculty and residents. As we were speaking a little bit about before the meeting started, things were a little bit different, a year and a half ago. Zoom was still a novelty, but we didn't want there to be a big barrier to entry. So what we started with was a community roundtable, and this took place in September of 20, and it was moderated by Dr. Taylor, our FBRMS faculty with training and experience in diversity, our hospital GME diversity chair, one of our community physicians that works in an underserved clinic, and we invited one of our very outspoken city councilmen to participate to help better reflect the community view. And really, we met ahead of time. Again, the last session I talked about was the pre-meeting before the meeting. So we had a pre-meeting where we just brainstormed and we talked about the things in a very open and safe space, virtually, of course, to voice the things that were on our minds, the questions that we wanted to get different players' perspectives on. And so that's really what we did. And I think the super interesting thing that emerged from this experience was we had a list of questions. We had questions about language. What do patients of different backgrounds prefer to be called? There were a lot of questions about that, what's appropriate to say. And what really emerged was something totally different, which then has since driven some of our additional efforts. So for example, and we didn't know this at the time, but the city councilman that attended and participated had actually received care for his wife and subsequently their children at the clinic where our residents practice. And so he shared that experience of being on the other side of that and how that has then affected his advocacy work on the city council. And one of the things that came out of that was that there are obvious structural, physical inequities in the building and the outside of the building. And we hadn't thought about that before. And so it really was idea generating for future things. Moving on, our next event was a recruitment, diversity, and equity round open house, on Zoom, of course, that we timed with the start of our recruitment session and invited through Instagram, which of course I needed my residents' help to do. All of our applicants, if interested, to participate in a discussion with us based on the New England Journal piece, Interviewing While Black. And so again, we met ahead, the committee met ahead virtually and came up with the list of questions. I served as the moderator to help drive the discussion, but I really tried to step back and let, in particular, our learners ask questions and share their own experiences and anxieties about the upcoming interview season. Last year, we had a real rock star resident who had a particular passion for this, and she was able to set up a book club. Our residents do a monthly book club themselves, and so we sort of hijacked one of these events, and we had Dr. Deirdre Cooper Owens present a discussion on medical bondage, race, gender, and origins of American gynecology. And that was really awesome to have that FaceTime with somebody with such experience and perspectives. Going forward, the other thing I'm going to say about that resident is because this was all new, we really wanted to acknowledge and honor the work that she did. So we did create a DEI award, which we gave at graduation to help acknowledge what she did and also hopefully motivate other residents to do the same. And then this fall, we did another roundtable, which we did again open up to residency applicants off of the New England Journal roundtable discussion, race and medicine, genetic variation, social categories and paths to health, and attempts to dismantle systemic racism in medicine. And I moderated that with one of our second-year residents. And again, we met ahead to review ideas and some topics for discussion. But again, just creating that open forum and showing up, I think really opened some lines for communication. So I wanted to, after reviewing our timeline, just go over for another couple minutes. And I hope this is okay because this is going to sort of lead into my question time, but I think it's just going to be a better format. Barriers that you see at your institution, opportunities that you have, and maybe experiences in this arena to share.
So if you have anything to share, unmute yourself and please speak up. I think we have a quiet group this morning.
So I'll share, I mean, one of my hesitations was in stepping into a leadership role in this area because I'm a white woman. And I do think that was some awkwardness, but I just decided to own it and say that, like, I'm here to learn, I'm here to be vulnerable and share. And so I think just acknowledging that potential awkwardness and willingness to learn and acknowledge that maybe you're not doing things great or as ideally is really important.
In the chat, buy-in is a barrier, and being an accomplice as well.
Okay, so a certificate in DEI is offered at different places. I know Cornell offers one online, and it's not a formal degree program, but it is something that you can pursue. Yeah, I think going back to the initial call out meeting, I think that it's easy to show up. We wanted to include everyone. And so what we've created with these events and the ongoing work with the committee is that you can join at any level. So you can show up for the Zoom open house or book discussion. You could read the book on your own if that time didn't work for you. But also opportunities to lead. Yes, we have considered the entire department. I think the next question from Dr. Armstrong. So in our department, we have extended membership to medical assistants, janitorial staff, nursing. I think that that is really the next step, because especially, and I spoke really candidly with one of our applicants at one of the recent interviews. You know, we do so much work to increase our recruitment, but then we need to make sure that not only within the department, but within the institution, within the offices, within labor and delivery, that we are helping to create and perpetuate safe spaces for our learners. And so I think that that is really the next step, is to expand that into the support staff and really making it a communal effort. Buy-in from the chair is super helpful. Yes, we have an amazing chair who leads by example and really opens the doors for other people to lead. And so I'm very thankful for that as well. In the interest of my time's running out. So I think, yeah, a lot of good points here. I think taking stock of both the department and institutional resources is critical. I think resident, not only buy-in, but leadership and pushing them to really, you know, take time away from their busy clinical schedules and do this meaningful work is really important, because really we have so much to learn from them. And obviously forums like this to share experiences and ideas is great as well. And I saw one other comment. Our committee is different faculty and residents, so whoever really wanted to be on it. I think the other interesting thing is, as we've done this, there have been sort of some correlate projects that have come up. So not within the diversity, the DEI committee, but looking at doing a large scale community service project with our faculty and residents to help benefit our clinic patients. So that's been another thing that has been great in coming out of that. So like my favorite podcaster, Dr. Brene Brown, says, be brave, awkward, and kind. And I think that as we move forward in this work and just trying to do better, that it just starts with an openness and leaning in. So I thank you for your participation, and I look forward to hearing from the other presenters.
Dr. Pollack, thank you very much. We still have a couple of minutes. If anyone wants to ask a question, just unmute yourself.
Hi, I just had a question. I applaud you on your work, your diversity work and your efforts. What were your goals? What goals did you want to accomplish in development of this committee?
Honestly, I think we just wanted to raise awareness, and to begin with, I don't think we knew what we were looking for. And I think that each sort of event and the ongoing conversations have shed more light into what exact sort of practical things we need to work on. So such as expanding diversity training and expanding these conversations to a larger audience. The conversation that came from our community roundtable really opened our eyes to how we can advocate within our own institution for better physical structural equity for the spaces our patients are served in. And really, we didn't know that. That was something very concrete that we hadn't really, I mean, it sounds obvious after your attention is focused on it, but I don't think that we knew that we could have an impact on that before we talked about it.
Right.
Hi there.
Margaret?
Yeah, hi there. Hi, Susan, and hi, Rebecca. Great presentation and great insight. One of the things that we struggle with are clearly, like Carol says, is goal setting, but also, you know, what are the measurable outcomes, right? That we could really say that this translates to success. And then when you're falling behind on getting there, how do you recapture that momentum that you first used to get started on this path so that you can get to that end point?
I think that there's different stages. So in the beginning, we were more like information collecting. And I think now we need to, now that we have some experience and some scaffolding, we need to recenter. And so I think when you do get stuck, you just need to take a step back and clarify your goal setting, reassess, you know, do a SWOT analysis and see how you can move forward in those goals. I think that, you know, one thing that's hard to measure that I have experienced is the number of applicants, both of applicants of color and Caucasian applicants, that have said to me how meaningful it was that we even put the DEI roundtable out there, that signaled to them that this is something that we're actively working on and interested in. And so while that's not something that I guess if we gave a survey that would be measurable in some fashion, receiving that feedback has been a huge motivator to me to keep planning.
All right. Thank you so much, Dr. Pollock, for your presentation. Round of applause. Our next session is why our medical students aren't master adaptive learners, creating the optimal learning environment. And Dr. Carino, that's for you.
Thank you so much, Dr. Paula. Great presentation, great opening to a session. And let me just start. And I just want to put this quick warning. Each and every one of the topics I mentioned is worth for a whole faculty development seminar on its own, and it can for a week or two. So if you can, please go to polleverywhere/ccareno so we can just do a little bit of interactive polling if we can. So the first question is, if not, we can answer in the chat and someone can moderate. An optimal learning environment is essential for a master adaptive learner to develop. And okay, let me see. Let me move to the next quick question. Mistreatment is the same as a hostile work environment. Okay, hopefully we'll address and we'll do more questions in a second. Oh, okay. So let's just talk for 1 second about the perception of the learning environment. We must align the teacher intent with the learning perception. We don't want to create a hostile work environment. I'm sure no one in this chat, no one in this faculty development seminar goes to work saying, okay, my goal is to mistreat and create a hostile work environment today. So our goal as teachers is clearly to make sure that our learners understand that our interest is to teach them to make it better. And we also have to do a better job at making our students understand that when we challenge them, when we push them, when we motivate them, we're not creating a hostile work environment or simply mistreating them. Well, optimal learning environment, great question. Is there a true and standardized definition? I couldn't find one. Could they be a spectrum of optimal environments that lead to a real, true environment where the student flourish? or move forward? And does it mean that if an environment is not hostile or suboptimal, does that qualify or make it better or optimal? I don't know about that. Where do we set the bar? I'm going to be arrogant a little bit more than usual and try to define optimal learning environment. This is my personal definition. It's a utopia simply, where the learner is going to follow their dreams of becoming an outstanding healer, learning the best practices in an abundance of theoretical and practical experience, in an abundance, in a stress-free environment where psychological safety prevails and fear is not part of any equation. Let's see if we can rank this. What is essential to a suboptimal learner environment to happen? The rotation did not help me grow. I felt I was not part of the team. I was not made aware of my weakness or inequalities. No one empowered me to apply my skills. I was concerned about the patients. And I know it's going to be a little bit cumbersome to rank it in the font, but these are the most common subsets in medical student evaluation and residence evaluation that I could find that can potentially lead to a suboptimal learning environment. In the chat, I felt I was not part of the team in the rotation, and that essentially that feeling of being ignored is what troubles the learner the most. It all starts here with the cognitive dissonance. I think we are all here because we believe we're training a new generation of excellent physicians and leaders in our fields. And the question is, are we really? Because the truth is that the inside of that discomfort is what leads us to come here every year to put our faculty development seminars to continue to do research in education. Well, we need to remember this.
No way. That's great. Landed on the moon.
And whoop. So we landed on the moon, but yesterday I put burnout as a title in a PubMed search. It came back to 8,300 search, 8,300 hits. And the subject of my presentation, Master Adaptive Learning as a general search, 50 entries. In the title, 6 entries. And when we look to metacognition in medical education in the title, only 3 entries. And when we look title and topic of self-regulated learning and medical education, 61 entry. We landed on the moon in 1969. Wow. Why haven't we been able to define or inform or create a learning environment today in 2022? How come burnout is still on the equation and is getting worse? And why in this era of equity, I was still talking about mistreatment as a core issue. A hostile work environment can have more detriment and lasting negative effects than mistreatment. Okay, I'm going to move on. Whoop. Whoop, I'm having some technical. Okay. I guess one second. Okay, it froze my computer. Okay. So really quick, I'm not going to go into detail into the work by Dr. Kotler and all of the creation in the interest of time of what a master adaptive learner is, but it's loosely based on a PDSA cycle where the do and study interact with the learning and assessing plan. So essentially start with a cognitive moment, a moment of self-doubt, of self-reflection, where the learning sees a gap. And this gap motivates the learning to investigate, to research and knowledge and practice and practicum to actually fill that gap. And that cycle in self fits itself into essentially learning a learner who's gonna find gaps in the training, find learning's deficiency, and it's gonna put tools to make sure that gap decreases and evolve into a learner who's constantly trying to achieve excellence. The goal of the master adaptive learner is to work into what we call this optimal adaptability corridor, as described earlier by Dr. Kotler, where expertise and innovations come together to constantly evolve. We need to look at the mirror, and can we aspire to develop a master adaptive learner if our team, our educational leadership is not an adaptive teacher or an adaptive educator? We need to train the trainer. And we need to learn as educators and teachers how to receive feedback from the learner. If our learners perceive that we have a hostile or suboptimal learning environment, or that they are being ignored, we have to address those issues. So where should we focus? The learning environment should not be targeted exclusively to the learner. The learning environment starts at the chair by the department curricular leadership. Program directors team is crucial. The core faculty, and I mean core faculty because I don't think every faculty will be teaching or training our learners, our residents, and our medical students. A master adaptive learner relies and depends on an adaptive teachers. I tend to agree with that answer. And this was an editorial that I hope everybody, it's a short editorial to Academic Base in 2019 that relates the journey of Dr. Eje when that becoming program director in finding the gaps that he had with faculty members that had more experience than them in education, that led to that program director to do a fellowship into health education to try to fill the gaps and try to adapt and balance the core curriculum and the accreditation requirements into the program. I was very motivated by this, and I suggest everybody to have 2 seconds to read it. We have a duty and a responsibility that our program director team, our educational leadership, and our faculty must become master adaptive educators. We need to create and define and raise awareness that our educators have to have adaptive expertise, and our learning environment has to be tailored to support and growth, not only adaptive educators, but adaptive learners. What is a master educators? And I'm going to try to fly through this really quick. Is we need to encourage and ask of our students, what do they want to be and what do they want to become? The educator has to have pliability to meet the learners where they are. And I say pliability because not every student is at the same level at the same time. Not every resident is at the same level. We have to come to where they are. And this is something has been very difficult for me to understand over the years. And of course, we need to also has to incorporate feedback. So our master educator is consistent qualities between the teacher and the learner. I'm just going in the interest of time, just mention a couple of things really quick. An educator has to be honest, has to be humble, and needs to be trustworthy. We need to teach the learner to think about how they are thinking, to think about their education, to think how they are being educated, and to think about how to maximize their educations. And we have to set expectations. We have to find the roles. We have to find the rules, and we have to define how we want our learners to learn. We need to start teaching failure and challenge. We need to start teaching grit. We need to start resilience and acknowledge that all of this can be taught in a huge expanse of safety net. Our learners have to feel that they have the safety net to fail, to acknowledge their mistakes, and to be motivated to move forward. Is there a learning environment for the master adaptive learners? No, there is no definition in the literature. There is no clear demarcation between mistreatment and suboptimal learning environment. Do I need to keep using the word hostile? My God, to me, suboptimal learning environment is as or worse than hostile. Can we acknowledge that there are institutional differences where a learning environment seen as optimal in one institution can be suboptimal or not adequate to other institutions? And I want to emphasize the importance of educational culture. A master about adaptive learner needs to have a prequel, needs to develop metacognition. By metacognition, I mean awareness of how we think. Cognitive dissonance, meaning that there has to be a sense of uncomfortable, that learner has to feel that desire to learn or to improve, to acknowledge a gap in knowledge. Grit and resilience, of course, and self-regulated learning. All of this needs to flourish. How are we doing on time, Dr. Cox? 5 minutes, or do I need
5 minutes to go, so that includes your question and answer period.
Okay, so listen, in the interest of entrance, let me just advance to this, what I want to see. So we can talk, I have a discussion. Whoop. So really, whoop. Whoops, sorry about that. Okay. So how do we train a master adaptive learners? And I want to open the focus of the discussion here. What do we need to do? Any questions in these 5 minutes?
Carol, your hand is up. Do you have another question, or is it up from the last Q&A?
Hey, I have a question. We are very eager to do some sort of curriculum at my institution for teaching faculty and residents basically how to teach. I feel like we've got some older faculty that sort of have outdated methods that the students don't really respond to very well, and then, or the residents. And then some of our younger faculty, I think, are a little bit less likely to provide that safe environment. Sometimes they tend to have a little less grace with people when they make a mistake. So sort of educating them on that. Do you have any resources or advice on that?
I think that there is no such a specific resource, but I do think that we have to start using executive coaching to our faculty and to our residents. I think it is key and it's paramount that the department leadership starts coaching to teach our faculty how to teach, how to lead, how to coaching, and then how to lead, how to teach, how to be better educators. And I don't know if that answered your questions, but there has to be a paradigm shift in how we see education in the current setting. We have to start teaching critical thinking in a stressful situation, especially for our specialty, OB-GYN, who's a surgical and medical specialty. But
other questions for Dr. Carino? Trying to monitor the chat. Faculty development, metacognition is a passion. Okay. No questions from the audience? Any last words, Dr.?
I think that well, thank you for the opportunity to present, and of course, thank you my co-authors on this. And I think that the take-home message that I take from teaching every day is that we have to focus on developing individualized learning plans. We have to see each learner as an individual entity with different deficiencies and different skills and different attributes. We have to stop linear learning. We have to stop trying to bring everybody to the same level and find out the deficiencies and where everybody is to excel and target a plan to each and every different person. I don't know how can we do this, but thank you very much.
Thank you very much for your presentation. Very informative. And now for our last presenter of the roundtable series, an obstetrics and gynecology clerkship app focused on completion of the APGO medical student educational objectives, and it's Dr. D. Terese. And I'll let you introduce your team and other team members.
Hi, my name is Rachel D. Teresi. I am at the University of Kansas, and I'm the clerkship director at our Kansas City campus. And this presentation is brought to you by myself and Dr. Kelly Crace, who's our residency program director, and Adam Bradley, who is our coordinator for our clerkship. So welcome. So this topic is Learn, Lunch, and Launch. It's a faculty development series that will send your clerkship into orbit. All right, so what was our initiative? Our initiative was to develop an interactive monthly virtual lunch hour session to focus on important topics that pertain to learners. So just to kind of review this talk, what our objectives are, we're going to learn the goals of the educational lunch series, review the series format and target audience, review the topics to be discussed, and how to engage participation and potential barriers. So the goals. So for the for the University of Kansas Medical Center, we are a tri-campus faculty or tri-campus institution. So we have different locations across the state. So we thought that this series, or this lunch series, would be able to bring in faculty from all the campuses to facilitate conversations and share best practices. We also thought this would be a great way to connect to our academic community and rural preceptors together to have meaningful conversations, as oftentimes our rural preceptors may feel isolated from the educational community at the academic centers. Finally, being a clerkship director, I think we're always thinking about, what are the areas we need to target for improvement for our clerkship. So this is a great way to reach out to your faculty who are distributing education to the learners to really focus on those areas that, you need to improve on for your clerkship. And finally, if you are not aware, APGO has an amazing effective preceptor series that has several topics with short questions and pamphlets to provide faculty development. Oftentimes those are really only seen by your educational leadership. So this is a really great way to implement that series to a broader range of the educators at your institution. So who is our target audience? Well, essentially, you really need your clerkship and your residency program directors to be involved in these conversations, because we're really seen as who in our department is supposed to be the experts in this area. Also, you got to bring in your clerkship administrators and program managers into the conversation. They often have perspectives that we are unaware of, that students need information more on. Academic faculty are a necessity because they are the ones providing education, but also you should have to consider your your advanced practice practitioners, as oftentimes they're also paired with our students and they're important to the education process. As already said before, bring in community and rural preceptors, because it's oftentimes they don't get to participate in some of this faculty development that we have at our institutions. And finally, right now we don't have residents in our conversations because some of our topics do involve residents in general. So, but that is somewhere we thought maybe would be a potential bringing more into the conversations. So our format. So currently it's monthly, every month, except for 1 month when we had interviews. We did that because we wanted to, we didn't want to do every weekly. That's a little, we thought that would be overburdensome. And then every quarterly may not help facilitate those relationships and conversations as well. So we do monthly, and it's virtual because we're across different cities. And so that allows us all to be together. And we chose the lunch hour. The lunch hour kind of gives it more of an informal feel, but also with the world of having so many virtual presentations and meetings, oftentimes we're asked to come in before work and stay late. So we thought this would be the best time that we might be able to reach most people would be over the lunch hour. These sessions are moderated by clerkship and residency directors. We generally alternate presentations, and the person that presents and moderates generally is a little bit more comfortable with material. So each session starts off with a 5 to 15 minute introductory video or PowerPoint. It's quite simple, actually. If you're going to choose a topic from, if we use a topic from the Effective Preceptor series, we just use the video that's attached. It's generally about 5 to 7 minutes. And then if it's not a topic on the preceptor series, we will either create a PowerPoint ourselves or we elicit help from somebody else in the School of Medicine or at our institution to help bring in. So we'll have guest speakers come and do a short presentation. Following that brief presentation, I think most of our learning really comes from open forum discussion. So we'll spend anywhere from 30 to 45 minutes just talking to each other and learning from each other about best practices. For example, I think really great we've had discussions about feedback and teaching the OR setting. I've learned amazing things from our role preceptors that I haven't used in my practice. But generally when we start this open forum discussion, we will, the clerkship director, which myself, and our program director will kind of talk about best practices ourselves first and then open up to more to that conversation if nobody's speaking up. But generally it leads to a really in-depth conversation I think that everybody learns from. So the topics to cover, so an easy starting point to create one of these is to just look at the Effective Preceptor series. This is a list of all the topics that we've done at our institution or will be doing it in the next few months. We just started it this year, so we haven't done a year completion yet. But we have already done providing educational feedback, teaching strategies in the OR and the ambulatory setting. We're going to be doing the preceptor and cultural competence in the next few months. Other ways to identify topics is to really just look at a needs assessment. What do you need to be talking about to help improve your learning environment, your clerkship? So we looked at student and faculty feedback, course evaluations to see what were some common trends and themes, things that we need to focus on to really improve. So we looked and found learner mistreatment, feedback, or common themes, unfortunately, and that tends to happen in the obstetrics and gynecology field. So we really focused a lot on those in our first couple of sessions. Other things we found from the faculty side is like, how do we engage that reluctant learner? Then you can also utilize a series to do some housekeeping topics. So as you know, we had recently LCME visit. And so this is a good opportunity for you to really kind of do some of those housekeeping things like reviewing your syllabus, looking at objectives, policies, things that, we say we do, but we really could talk about a little bit more in depth. Letters of recommendation, we did this right before interview season and before those letters were due. So we had a nice conversation about like, what does a good letter look like, and reviewed some of that content together. Other things we identified, currently we are seeing an increasing number of students who have accommodations. So with that occurring, we felt it was really important to have a conversation about supporting learners with disabilities. And we had an outside speaker from our School of Medicine, not outside, we had a speaker come from our School of Medicine who is in charge of and really involved with creating those letters for accommodations, come and speak to us about that. And finally, upcoming, we're going to talk about educational leadership, talking about promotion, and that'll be in the future topics. I attached here on the slide, this is an example of what a PDF would look like that you can attach. So following these, usually if there's some information, we attach it as a handout at the end of our conversation. So faculty engagement. So how do we get people to engage? I think that's the biggest thing. One great thing about this is that you can attend from everywhere. It's virtual, right? You can engage people from different cities. Consistent schedule. We chose to make it the first Monday of every month during the lunch hour. It's just that consistency. So then it could trigger folks to remember, hey, there's a session I can go attend. I like to use text message reminders. So our generalist division has we have a text chain that we communicate to each other pretty commonly. So right before the session, I will generally send out a message to them and say, hey, don't forget we have our learning session. And generally every time I do that, I get about 3 to 4 people who pop in because they, oh, great, thank you for reminding me, and they'll pop in and join the conversation. When we initially created this, we really wanted to provide some food and beverage as an incentive to come and hang out and talk about education. With COVID, though, we haven't done that yet. We hope to in the future. That will be our plan. We do have support from our department for funds to provide food and beverage. So at some point we will do that. I think another thing to point out how we get folks engaged is we have an incentive. So our department has funds that are set aside and you can receive when you participate in educational activities that are not RVU producing. So if you attend, you can submit saying you attended this and receive a portion of that, a salary for that. So barriers. So what are some barriers to implementing this faculty series? Time. I mean, I think we're all burdened with time. It is hard. We're all very busy. So asking people to add something to their plate can be a difficult ask. Burnout. So just with time and burnout go together. So that's why we try to minimalize interfering with schedule and put it over a lunch hour and keep it pretty informal. Just pop in and have a conversation whenever you're able to during that lunch hour. So looking on for our next steps, what do we want to do moving forward with this? We haven't had a year under our belt yet, but looking at some things that we're already thinking about, we'll probably consider adding residents to certain sessions because I think they're also they're educators in our world, so they would be important to bring them to the table. Recording the sessions, we are going to start recording them so that persons who were, maybe they had a case, clinic went over and they couldn't come to our session, or they're just burnt out and can't attend, then they can look at the recorded session at a later date. And then I think my big goal for this moving forward is to bring in other specialties and departments. I think it's vital for faculty development, not only to learn within from ourselves, but to branch out to other different departments and learn from them and see how they are approaching situations so we can better ourselves together and collaboratively. All right, so I talk pretty fast. I'm really sorry about that. But I kind of wanted to open this up to bring in some questions, have an open discussion about barriers to implementation at your institution, other topics, how to engage participants. So the Jamboard, if we want to open that up, I will put it in the chat. Okay, so Adam is our clerkship coordinator, and he put it in the chat. So if you'd love to pull up that Jamboard. And I'm going to pull it up and share it with you. Okay, can everybody see that? Okay, love it. So feel free to unmute yourself and have a conversation. I think that's what I really love about APGO, and it's hard doing this virtually, but feel free to unmute and ask questions. I think that's how we best learn from each other. Everybody's so quiet.
Hey, Teresa, this is Becky. So from the faculty perspective, do you rotate, or do you have this time set apart each week that you're free? Because for a lot of us, that academic time rotates, so it is hard to have a consistent thing.
So do you mean moderating, who wrote? Yeah, so we generally will rotate. I will rotate. I'll moderate 1 month. We both try to attend. It's because it's really ran by myself and the residency director, so we both come together. But oftentimes I'll be on nights or call, and so we'll switch, and that person will lead the session. And we generally will have our assistant directors come too, and so they can help continue the conversation if you can't be there. So I think with just having that preceptor series already there, you have a ton of topics that you don't really need to do extra work to develop it. I don't put an excessive amount of time into this. So I know we are all exhausted, but you already have a video and you already have probably done a lot of development yourself. So you can really just talk about best practices and then open up for a discussion. So it shouldn't be a lot of work going into it before.
And let me ask you a quick question. What kind of metrics are you using to see what do you need to change? What do you need to add? What do you need to improve?
I love that question. So currently we don't have any metrics. I was thinking about that listening to other conversations. What can we do next? And what can we look at? I don't have an answer for you yet, Carlos. But I think what we will be looking at is it won't be completely direct, but I will look at our evaluations. I think mostly we'll be looking at mistreatment and feedback, because those are our top two things that we want to work on for our clerkship. So we'll be looking at that to see if we see any improvements.
What has the attendance been in terms of like ratio of students to faculty? And also, is it mostly students that are in the OB-SIG on the rotation? Is there longitudinal participation?
So yes, so it's only faculty that come. There's no students involved that come. It's about 10 to 15 folks that will come across all the campuses. We have pretty common theme people who will show up, but with the text reminders, I have noticed people who weren't coming before now starting to participate a lot more. So I would say about 10 to 15, and a lot of it's rural preceptors too. They really, I think, the target audience that I'm seeing now that we've been doing that is the rural preceptors. I feel like because they don't really get this because they're out in the community. So I feel like, and we've gotten the best feedback from our rural preceptors.
Rachel, there's a question in the chat. Can you tell us more about your department education incentive?
I thought I'd get asked about that. So so we have an academic incentive committee. So like I said, there are funds that are in a sense withheld from the department. So there's a large bucket of money. I don't know how large it is, sorry, I can't give you the exact, but there's a bucket of money that is withheld and then distributed based off what you turn in for academic incentive. So we fill out a Excel sheet basically of all the things that are what we have deemed as a department as educational that don't generate RVU salary. So we protect those persons who are spending a significant of their time not doing patient care that doesn't reimburse. Things that would be on that would be participating on committees, national committees, local committees, lectures, research, mentorship, a lot of things like that. And so attending faculty development is also on there.
Another question, do you have other resources outside the APGO Effective Preceptor series you would recommend?
So I really think bringing in places from your own institution. So if we look back some of the things we talked about, finding experts in your school of medicine and bringing them in to do short talks, I think is actually pretty helpful. My goal doing this is to make this as easy as possible to run. So other than that, I think there was another one, was the academic one.
I'm trying to remember. I can't think of it off the top of my head.
We're blanking. There's one that is more geared to talking about promotion for leadership under APGO. I can't remember the name of that series, but that one we're going to be utilizing moving forward. But really just looking within your institution. And I think making connections here, because that's why I secretly was thinking, Carlos, of you coming and speaking. So trying to make those connections with each other and having some prisoners come.
Career development series.
There's a career development series on APGO.
That's right.
That's what it is. That would be also a great resource.
A follow-up question to the prior question from Meg O'Reilly. How does the incentive thing work for your non-academic preceptors?
So that's a little kicker there. So it's great for the Kansas. So I'm on the Kansas City campus, so they won't have that. So that is going to be purely because they want to participate for themselves. And I find that that need isn't there for them. because we get a lot of positive feedback from those preceptors out in the rural setting, and they don't receive any academic incentive, and they really enjoy it. But it does help with their volunteer faculty appointment. So for us, it's
They have to be renewed every 2 years.
they have to be renewed every 4 years. So for them participating helps with their renewal.
A comment from Kate, which I think is very appropriate with the virtual world we live in now. It is easy to get outside speakers that are fantastic from all over the country because they don't have to travel. So that's something for y'all to keep in mind.
And it's short presentations. You don't, because I think so much of this is really from the conversation and not the presentation. The presentation is to give like a little snippet of information, but really talking is, I think, where all the learning comes from.
Yeah.
So it makes it more fun than listening to a presentation for an hour.
So we've got about a minute left. I wanted to thank our 3 presenters. Those are outstanding presentations and sessions, and want to thank you for staying on time. That made it very easy to moderate. And I think we'll end now, so you can go grab a little lunch or late breakfast or whatever time zone you're in before the next plenary starts in 5 minutes. Thanks, everybody.